Welcome to the Minor Consult, where I speak with leaders shaping our world in diverse ways. Today, I'm thrilled to be joined by Dr. Vanessa Kerry, the first ever Special Envoy for Climate Change and Health at the World Health Organization. Vanessa is the founder and CEO of Seed Global Health, a nonprofit that has provided training for more than 34,000 healthcare workers in 7 countries. She's a passionate advocate for health equity and a champion for building out sustainable health systems around the world to create a healthier future for all. Vanessa, welcome to the Minor Consult. I'm delighted to have you here today.
Thank you. I'm incredibly honored to join you.
Vanessa, it's my understanding that your interest in global health was sparked at an early age. Can you tell us what set your course for your career?
When I was 14, I had the opportunity to go to Vietnam at a time when the country was still actually living with under the embargo that had been put in place at the end of the Vietnamese War. And so the country was really frozen in time. I mean, cars from 30 years ago, this was back in 1991, dating myself now. And there really was not a lot of development in the country. There's not a lot of electricity. There's not a lot of running water. And I just remember being young, not having seen a lot of this world, and driving down the roads to visit places that were part of our history, shared history with Vietnam, our meaning the United States shared history with Vietnam, and seeing the scars on that country and not being able to necessarily understand it at age 14, but being really struck by it. And the thing that struck me the most was the poverty. There were so many kids that didn't have clothes. They didn't have, you could tell there wasn't running water, lots of concrete houses without windows. We went to an orphanage where a young child came up and asked me for my shoes. And I remember being really freaked out because I remember thinking, I want to give this child my shoes, but then what do I wear? And the level of confusion as a 14-year-old was pretty big. But what I walked away from was this unbelievable sort of eye-opening realization that the world didn't have necessarily all the things that I had or all the things that we even had access to or had the option for in the United States. And it stuck with me. I had no idea what to do with it. It just stuck with me. And so when I went to before I went to medical school, I took a gap year. I actually took 2. I lived at home so that I could save all my earnings, and I worked for a year and I saved everything I had, and I went and I traveled around the world, basically backpacking, right? Very inexpensively, and spent some time seeing other parts of the world. I actually went back to Vietnam. I went to India. I went to Nepal. And I recognize that's a really luxurious thing to do, to be able to do that. I was incredibly privileged to be able to have the opportunity to have earned my own money and to have the time and space to do this. But it left more of an indelible mark on me because it meant there wasn't just one country that had this, there were many countries that had this. And I just, by the time I went to Africa, which was the last continent I went to, I knew my life was changed. And I don't know if it was Africa itself, but I remember the plane landing and hadn't even touched the tarmac. And I said, my life will never be the same. And just when I went to medical school, I took all those experiences and said that whatever I do in medicine has to be vested in also understanding this global dynamic and how do we change the health parameters and bring the knowledge of, being a doctor to also all of this knowledge about the systems that exist in the world today or don't exist in the way that they need to, and how do we bring them together. And that led me through the series of steps of getting engaged in global health and the systems breakdown of global health. Paul Farmer was my mentor. I went to Harvard, and I was privileged to go to Harvard Medical School because at the time it was really the only place in the country that had this kind of global programming. And Paul was championing very much the anthropology and kind of the history and breaking down why the world has become what it has become and how to then think about how to remedy it. And all of that has very much shaped, the career that I've had today, and every experience I have today is shaping it.
That's so inspiring. And after you became a physician, you practiced medicine in Ghana, and I think you continued your focus on global health as you just described. And then you wrote an op-ed in the New York Times in 2010 where you outlined your vision for a service corps of healthcare workers. What did you see in your experience in Ghana and after that inspired you to write about this concept and then to do it?
So Ghana was actually my first job in the summer, my first summer between my first and second year in medical school. I was hired to conduct a study to look at the completion rates of a vaccine. And remember being given the study protocol and being sort of, sent to Accra, Ghana. And I had to go find the completion records of this vaccine because it was a 3-dose vaccine. And so mothers would bring their child in, the child would get vaccinated, then have to come back twice more for vaccination. And we're trying to see how successful this big public health campaign had been to be able to successfully see these children complete this critical vaccine. Because it's actually 5 vaccines in one, and it was being done by the Gavi. And so I was given this protocol that said, find 500 mothers randomly selected. You go to their homes, you're going to interview them. And very quickly, I realized there was no way to find these mothers because nobody had addresses, because everybody just comes to the clinics and gets completed, gets their vaccinations. And so if they were lost to follow-up, there was no way to go track these mothers down. And so I remember calling back to the team and saying, we're not going to be able to follow the methodology. We're going to have to do this in a different way. And so the study was inherently flawed because the only mothers we could find to interview were the mothers that continued to show up at the clinic, right? So we lost automatically those that weren't able to follow up for whatever reason. But it still told us of the number of mothers we were able to absolutely find. We still found a really excellent completion rate, but it was definitely a flawed study. But what was striking to me again was another system that didn't have necessarily the resources it needed to be able to provide care for the population in the way that they deserved. And so, that experience was incredibly striking for me, and it just reinforced this pursuit in the study of understanding the history of racism and colonialism and the structural readjustment programs that had, removed public sector investment into the health and the education systems in Africa in order to get into the neocolonialism. I mean, all these, I'm talking big terms that, and that was part of it. I didn't understand any of these terms. And so I ended up going to get my master's in health planning, policy, and financing at the London Schools of Hygiene and London Schools of Tropical Medicine because I wanted to understand that vocabulary, that history, those systems that seemed to be really interrupting the ability to give care. So as I came back from that and I continued to do clinical work in Uganda and Rwanda, I then started to have experiences where I found myself in inappropriate situations as a medical student. I remember I was on the labor ward delivering babies and there wasn't an obstetrician to be found. And I was considered the most top person because I was a medical student, even though the nurse had 20 years of experience. And I was looking to her when, women were delivering and to figure out how to have this child come out. And one child got stuck. And I, for the life of me, couldn't remember the maneuvers that had to happen. And I did finally remember one. And the nurse and I discussed it and we delivered the baby safely. But it was so inappropriate for me as a medical student to be delivering a child. One, just as a medical student. Two, not trained as an OB. But there weren't enough physicians to manage everything happening. There weren't enough nurses. And then I came back to my residency in the United States, and I was at Mass General. And, God bless those days, you'd be on call at the wee hours of the morning, and I'd be sitting there next to my friends who all wanted to do global health careers, and we're all talking about how to earn the money that we needed to moonlight, to find other ways to make the money so that we could then go fund our global health work for 9 months a year. And it didn't make sense to me to be working in places that didn't have enough doctors, didn't have enough nurses, didn't have the workforce they needed to provide the care for patients, to then see on the U.S. side a huge amount of energy and interest that wanted to be doing global health, but had no mechanisms or programs where they could build on something year after year. It was all haphazard, going where you could find a way to fund yourself. And so it just seemed to me silly that there wasn't a way to bring these two things together. And I believe deeply in service and public service, and I believe deeply that there's a role for the government to fill in some of these market failures. And I'm sure I'll never have a career in politics for saying that out loud. But it seemed to me natural that the U.S. government could step in and build off its work with PEPFAR and build off some of its work to be able to actually create a program that harnessed that energy and was in service to building the capacity in the places that they work behind the priorities of our partner countries. And so a friend and I, Sarah Auld, the co-author on that paper, and Paul and I actually, so that New York Times piece, my colleague Sarah Auld, Paul and I wrote a piece that got published in the New England Journal of Medicine. And it got published, and it's a big deal, right? And I, at this point, was batting pretty well. I had a New York Times op-ed. I had a New England Journal. I was like, this is great, right? And someone came up to me and said, congratulations, you published in the New England Journal of Medicine. And I remember where I was standing on the quad at Harvard. And I remember being really struck, being like, what are you congratulating me for? I haven't actually done anything. And I said to the person, congratulate me when it's actually done. And that became the effort to say, okay, how does this get done? And so my colleague, Sarah, who co-wrote this article with me, she's actually a Stanford grad. Sarah calls me one day and she says, I'm on call, but the director of the Peace Corps is coming to Boston and you need to go and ask him to create this program or see if he'll do it. So I went to this forum with the then Peace Corps director and 3 former directors, and I stood up in the rafters and I raised my hand anonymously and I just I asked the question, what do you think about the Peace Corps sending doctors and nurses abroad to be educators, to teach, train, build capacity as part of a federal program? And the 3 former directors who had no skin in the game instantly answered, great idea. And the then director must have known that I was not going to leave him alone because he paused. But Aaron Williams then said, it's a great idea. So I went and I introduced myself at the end. I said, I want to send you the proposal. So we sent him an unsolicited proposal to kind of put this program together, and that was the birth of Seed Global Health, because there was desire for these countries to have more technical capacity. There's a realization coming out of PEPFAR at the time that there's a goal to train 140,000 healthcare workers, and we realized we could bring the technical expertise and to really build this program. We had a wonderful 5-year partnership with the U.S. government, and the program actually still exists at the Peace Corps. So it's a very cool thing.
That's wonderful. And over more than a decade, SEED has helped train thousands of doctors, nurses, midwives, and other health professionals. What were some of the challenges you faced in developing SEED and then in scaling and expanding it? And what do you think has been most effective about SEED? And what advice would you give to people who are contemplating similar initiatives?
I think, it's remarkable. I just heard from the team that the latest count is that SEED has trained over 47,000 doctors, nurses, and midwives over this last decade, and that we're in service to catchment areas of over 76 million people. And, I think that that's really humbling, but it's also a drop in the bucket. There are over 53 countries around the world with critical shortages of doctors, nurses, and midwives. And as we've seen in COVID, without question, there were, our investments in health have not built the kind of resilience and strength that we need to meet a lot of these challenges. And I really believe that investing in the health workforce is actually the leading edge of being able to rise to these challenges. Because a healthcare worker, health is fundamentally a human-centered intervention. And we've seen this day in and day out with SEED. When a woman is hemorrhaging, it is a healthcare worker who holds her hand, who identifies the shock, and who hangs the bag of blood. And I think that we forget that AI and technology are going to go a long way, and they can leverage, but they leverage in the hands of healthcare workers who can make sure that that goes the right way, or there's answering the right questions. And so you need to have that link without question. And a healthcare worker will also prioritize for you what the needs are. They will sound the alarms about where the system is falling apart and where the first investments can come. So investing in health systems is not a daunting thing. It starts with a healthcare worker. And from there, the rest can follow. And I think that the main challenge I've seen at SEED is that people don't have the time, the patience, or frankly, the ambition to make the kind of investments we need to strengthen our health systems and build our resilience, to train a healthcare workforce.
And speaking about the state of the world today and other factors on health, through your work at SEED and other global health work you've done, you've seen and learned firsthand about the connection between our environment and our well-being. What are some of the ways that climate change has harmed public health in recent years? And maybe you can also talk, that would be a good transition into you talking about your work as Special Envoy for the World Health Organization on climate and health.
Thank you. climate crisis is quite simply just, is a health crisis. When you look at how climate change is, it's impacting our human experience in every possible way. It is ruining our security by the extreme weather events that, jeopardize our housing or our roads or our transport. It is, it is impacting, there's the direct impacts on human health from vector-borne diseases that are on the rise. We saw fourfold increases in malaria in Pakistan after the floods in 2021 and 2022. We've seen bridges wash away in Malawi where seed works, where then the birthing centers aren't accessed. And so we've had to rebuild birthing centers or support restaffing new birthing centers in order to ensure women have safe delivery. We've seen the number of people piling into beds because of malaria in the high season go from 2 in a bed to, I've heard, up to 6, or 8. So these are really real and direct ramifications of human health that span everything: non-communicable disease, vector-borne and communicable diseases, cholera that we're seeing in Malawi, cholera in Zambia, mental health, which is already an estimated burden of disease globally, and now it's rising immensely, and we see it in terms of poor maternal health outcomes as well. Every aspect of human health is being directly impacted by climate change, but there's the indirect impacts, which is the reality that if it's too hot, people can't go to work. They don't earn their hourly wages. They can't then afford their cost, their normal cost of living. It puts more strain on the house. We are seeing that as the rise of health burdens put economic costs on families as well, in terms of 25% of households that have a non-communicable disease will have catastrophic costs that can move them below the poverty line. So these are really real indirect costs that we're also seeing: food security, water security, migration. There's going to be 1.2 billion climate migrants in the next 30 years, 25 years. That puts pressure on health systems, that puts pressure on politics, pressures on borders. So these are absolutely, in many ways, the climate crisis is a health crisis is COVID on steroids. COVID was a canary in the coal mine for what we're going to face, because the degree of the burdens that we're going to see are going to rise so exponentially and impact so many around the world. Already half the world's population is being impacted by climate change today. So we are really, we're really looking at a growing crisis. And the other problem is it's going to make inequities worse, because those that are the most vulnerable to climate change are those that have the least amount of resources to adapt. And so that means the inequities that we're seeing in the world are only going to grow more and more right now. And that's really going to create increased tension, and it just is fundamentally unfair when you sort of think about, what's happening and how we're supposed to exist in the human experience. So I've spent 20 years working in health system strengthening, and one of the things that we realized was that our work was getting harder from climate change. Either the storms that were happening, the increases in diseases we were seeing. So we suddenly realized that we don't even have enough healthcare workforce in many parts of the world to cope with existing burdens of disease. It is going to get far worse with the growing burdens of disease. And so that led me into a conversation with the World Health Organization and Dr. Tedros about the fact that the World Health Organization can really help treat the climate crisis as a health crisis, and with the same urgency that we saw in COVID, and as a real public health emergency. And so with that, Dr. Tedros invited me to help think about how to support that work and that mandate, and to really be able to change the conversation and to have people understand the critical importance not only of climate change to our human health, but how that has impacts across our economies, our security, and other aspects of our lives in a way that hopefully we can motivate political leaders and others to make the right choices that we need right now, and to, what I call sort of our, I would call it our third pandemic. We had COVID, we have the climate change, which I think is a pandemic, and now we have a pandemic of expedient and poor choices from leadership that aren't actually making the decisions and investments we need to protect ourselves as we are confronting this new challenge.
There's so much to be done and so much need. In your role as the special envoy with the World Health Organization, what are you thinking about in terms of prioritization of programs that you're involved with, or challenges that you're encountering as you do the planning for having the type of impact that you describe we so need?
Well, I think first and foremost, we have to recognize and really lean into the fact that fossil fuels are driving climate change and driving these health outcomes and driving all of the challenges that we face today. So we have got to find a way to phase out fossil fuels, have a just transition, and put some real targets and timelines on that, and not do these backdoor deals, or not really, and not let some countries not make those immediate investments, who need to be some of them, and then part of that is the just transition for those countries that don't have the resources to make the transitions that are needed. And examples are like Zambia, where Seed works, that actually did, take away their fossil fuel subsidies, but then it's their population that's hurting because they don't have access to clean energy yet. And no one is helping them to make that bridge or transition. And so I think that we have to get very real about how to phase out fossil fuels and to ensure a just transition. We have got to prioritize more in the adaptation and resilience funding. So when you look, for example, there's not a lot of funding that goes into climate and health anyway, but even a fraction of that climate and health funding is going into the adaptation and resilience of health systems. So we have got to close that fundamental financing gap, because a country like Malawi, they have $30, $35 per capita to spend on health. They need 78 just to make a basic package of services. So we're talking 10 cups of Starbucks coffee, right, a year is needed for a basic package of services in Malawi, and they have even half that at this current moment in time. And so you're asking a country like that to build resilience in the face of worsening storms and more severe and longer storms. There's just a fundamental financing gap we got to find a way to close. And so I think that's another, so really building that money into the adaptation and resilience investments is going to matter. I think the third thing, there's sort of two more things that are really important. One is really recognizing that investments in health are critically needed and that they are savings, not costs. And so we know this because we've seen not only when you make investments in health, you see an actual financial return on investment, but we know this because we end up spending the U.S. lost $100 billion in productivity last year alone from extreme heat. That's going to double in the next decade. India lost $170 billion. We're seeing the economic cost of dengue be up to $9 billion a year. So we're seeing these costs that we're paying treatment. There's estimates that are going to be $1.1 trillion just to manage the disease burdens from climate and health between now and 2050. I mean, the costs, we're spending money to react. So we have to start shift our thinking a little bit and to really think about how we can invest in health for the long term. And one of the things I'd like to work on is to really build that value currency of health in the short term, so it becomes a cost of doing good business, is investing in strong health systems. And then I think finally we need to realize that we've spent 40 years pouring money into global health and into health investments that have not actually done the work they need to do, built out the strong health systems. And our response to climate change is no different, but it gives us an opportunity to do it right in a way that we haven't before. We saw 90% of countries have disruptions in services in COVID. If we'd been investing in strong and resilient health systems and the workforces we needed all along the way, we could have better adapted to that moment and not seen the rises of disease and disruption of services that we saw in the wake of that. If we fail to do that again in climate change, we're going to be even farther behind because of the scale at which climate change is happening. And so I think this is an opportunity for us to finally take some lessons learned and to change how we're doing this work.
The COP28 conference, the United Nations Climate Change Conference that took place just a couple of months ago, devoted a full day to the health impacts of climate change. How significant was that milestone, and how do you expect to build on the day's discussions and energy?
So COP28 was incredibly exciting, and it was historic that it had a first ever day of health. It was on the third day of the conference. It had very high political engagement. There were some very exciting funding announcements that came out of it, including $1 billion dedicated to climate and health was sort of highlighted. There was $770 million that came in the Reaching the Last Mile Forum to help manage some of the communicable and neglected tropical diseases, which is new funding. 148 countries signed on to the Climate and Health Ministerial Declaration, which was really a consensus statement about how there's a climate and health nexus and how much it is impacting sort of our well-being in the world. And we went from having 3 ministers of health in historic record going to COPs to having over, I think 100 ministries represented and something like 75 actual ministers of health attending COP. So there's a very different energy, attention, and focus on this primacy, which is incredibly exciting and creates an incredible opportunity going forward into COP29 in Azerbaijan and COP30 in Brazil. And there's the three COP presidencies have actually come together to create a continual sort of legacy that will continue through these COPs forward into COP30. And Brazil is currently the head of the G20. So there's a lot of opportunity to motivate some political excitement around this area. And I think all of that is really terrific. And there's a lot to be happy about. And probably one of the most historic things was the fact that the word fossil fuels was used to close the COP at all, right? So you started the COP with the loss and damages getting passed. It's the soonest anything of that magnitude has been passed during a COP proceeding. And you ended it with the recognition that fossil fuels was driving climate change, which is the first time we've actually seen that kind of language very used. And that is exciting. Now, the flip side of the coin is, we should be talking about phasing out fossil fuels, not just transitioning from. It's a little loose. There are no deadlines. There's no targets. We haven't really assigned some measurements to that. I think that, and so that's a problem. The Climate and Health Ministerial Declaration, while an exciting document, was pretty watered down and didn't even use the word fossil fuels, which really reflects the power of some countries to weigh in and sort of influence not putting fossil fuels in that language. And the $1 billion that was pledged for climate and health, over $800 million of that is already pre-pledged, pre-earmarked, and not new money. And so there's not actually a lot of new money available in this space. And so there's a lot of work to do. But I think when you have the kind of momentum and attention that we started with, that creates opportunity. And that's going to be a big part of my work, the work I think of a lot of my colleagues that have been in the space for a long time, the WHO, Dr. Maria Nera, who's really been leading the charge in an incredibly powerful way on the climate and health nexus, and others to continue to bring this momentum forward and to bring the evidence to bear in a way that we can get the policies changed in the ways that we need.
Wonderful. Maybe bring it close to home for our listeners. What actions can individuals take to help mitigate the effect of climate change on public health? And what can physicians and other healthcare workers do?
So I'm a big believer that if you are not thinking about this, talking about this, and contributing to the solution, you are part of the problem. And I think we all have an individual responsibility to take a hard look at our lives and the way we live it, and to think about what are the big or small decisions that we can make that can make our contribution to protecting the environment and to protecting our health. And so those can be anything from individual behaviors around recycling, energy use, to frankly having conversations with people to educate colleagues or to get educated yourself and to help champion this issue. I think healthcare workers have a very particular task, because part of our work now in protecting our patients and part of that kind of primary care sort of and prevention profile is going to be educating our patients about how to protect themselves in this climate change environment and how to understand the ways that climate change may impact their health. And that can be everything from understanding how to engage with extreme heat and protect yourself, down to the fact that buses that work on fossil fuels and are driving through your community actually increase the rates of asthma attacks and pulmonary disease than when you switch to electric. And so having people, I think, understand how their health can be impacted in really real ways by what's happening in the community can help to action some of that change for protecting our planet and protecting our communities in a much better way. And so we need to get educated as healthcare workers without question. And I think there's a responsibility for institutions like Stanford or Harvard, where I am, or other institutions, Mbarara University of Science and Technology in Uganda, where we work, to think about what those curriculums look like and how we can, in really contextual ways, help prepare our patients for what's coming. And also then, I think, also as advocates, as healthcare workers, we sit on an unbelievable amount of data, knowledge, and expertise that we have to bring to bear. We know that coastal communities and less resource settings are going to see upwards of, 800,000 hypertension cases just from the stress of what's happening in those communities, and that there's very real costs associated with treating those hypertension cases. How can we use that to translate for our policymakers not only what that health burden looks like on these communities, but what the economic cost is for these communities, such that we can also help our policymakers to make the right decision?
Vanessa, thank you so much. I want to end with questions that I ask all my guests. First, what do you think are the most important qualities for a leader today?
I think the most important qualities for a leader are integrity and honesty. And that means a willingness to have the humility to understand where we are in the world today, to have the humility to know that we might have made mistakes, even individually in our leadership, but that it's our job to know what needs to happen and to do it from a place of evidence, a place of truth, and a place of open transparency about what needs to happen. I think leaders need courage to make the right decision, even if it feels like it might harm your own personal trajectory or your own, pathway. And I think we've seen a lot of that where decisions are being made for political expediency in the next election cycle, not for what needs to happen to rise to this moment in the right way. And I think that we need to have that courage to really make the right decisions today for our own survival. And I think those are really the most important. I think also leading by example, right? We cannot be hypocritical anymore. And we have to be able to, I think, put our passion, our conviction to the test, and be willing to live the lives that we are asking everybody else to have. And I think when we do that, we're able to create a collective and to inspire people to also be willing to come into this moment with that same honesty, integrity, truth, conviction, and fight for what we need. One of the leaders that I've always admired the most, and I had the privilege of seeing him speak in Trafalgar Square in 2005, was Nelson Mandela. And what struck me the most about hearing him speak was his humility, his sense of deep connection to the people he was speaking to, and his deep belief in the good of people and the ability for change. And I think it is that forgiveness, despite everything he went through, it was his unbelievable conviction and willingness to make the courageous decisions that was able to inspire others. And he lived, his leadership style was very vested in incredible sacrifice, but an incredible, I think, belief in the power of people to do the right thing. And it made room for change. And I think we don't, in our society today, make room for people to be reformed or to change. We judge and we condemn. And I think that there's been a lot of mistakes made in recent years. But if we don't find a way to cross the aisle and we don't find a way to find our shared values and to build that kind of forgiveness, we're not going to be able to march forward. And I think that's, frankly, an opportunity. And I'm nothing but I'm an optimist. I really am.
Sure.
And I think that if we are able to have these right conversations and really figure out together what our shared needs are, I think we can rise to this occasion.
And on that theme of optimism, what gives you hope for the future?
That my kids are smarter than I am. I think what gives me hope for the future is a couple things. Some of it's historic. We've had dark moments in time before, and I think we've managed to come together, and I have to believe we can find our way forward, to come together in the way we have throughout history, and that the pendulum swings. But I also, what really gives me hope, I'm not joking when I talk about my children. It's unbelievable to see their wiseness about what's happening in the world today, their awareness and their kind of disbelief at how stupid we have been as adults. And, I have the privilege of teaching generations that are younger than me, and there's a lot of smart people who want something different and can see a different pathway.
Vanessa, thank you so much. This has been a wonderful and inspiring conversation. Thank you for listening to The Minor Consult with me, Stanford School of Medicine Dean Lloyd Minor. I hope you enjoyed today's discussion with Dr. Vanessa Kerry, Special Envoy for Climate Change and Health at the World Health Organization and CEO of Seed Global Health. Please send your questions by email to theminorconsult@theminorconsult.com and check out our website, theminorconsult.com, for updates, episodes, and more. To get the latest episodes of The Minor Consult, subscribe on Apple Podcasts, Spotify, or wherever you listen. And if you enjoyed today's episode, please rate the podcast 5 stars. Your feedback helps make this podcast happen. Thank you so much for joining me today. I look forward to our next episode. Until then, stay safe, stay well, and be kind.